And today we are joined by esteemed practicing nephrologist and a transplant specialist, Dr. Aseem Thamba, who did his medical school from University of Mumbai, post-graduation from Grant Medical College, and then his DNB from esteemed hospital, Jaslo Hospital in Mumbai. Currently, he's practicing as nephrology specialist and transplant specialist for more than 15 years at Jaslok Hospital and Wokhart Hospital, Mumbai Central. Thank you, Dr. Thamba, for joining us. Today he is going to put some light on prevention of CKD, chronic kidney disease progression, and off to you, Dr.
Thank you, Namaskar. Thank you for joining a small discussion in nephrology and one of my favorite topics, and that is how to prevent the progression of chronic kidney disease. Sorry, 1 second.
Start.
So I'll be talking on progression of chronic kidney disease, how to prevent the progression, and let us discuss a common scenario in our clinic when a 45-year-old lady comes to our clinic for a follow-up, and she has chronic kidney disease. She's a diabetic, she's hypertensive, and during the past 1 year, her estimated glomerular filtration rate, eGFR, has been in the range of 38 to 43 ml per minute, 1.73 meters square. She has a serum potassium, which is little high, around 5.3. She has anemia of chronic kidney disease. She has malaise, loss of appetite, some edema in the feet, and she is wanting to know whether she will progress into further deterioration in her GFR and land upon dialysis. So our role is to try to prevent the rapid decline in GFR. So let us see what are the strategies to delay the progression of CKD. I have the content of my talk. I'm trying to keep it short and stimulating. So I will be giving you a small overview of chronic kidney disease and the various strategies to delay the progression of CKD. So let us start by saying what is the definition of chronic kidney disease. A patient is said to have CKD if they have abnormalities of the kidney function or structure present for more than 3 months. These include all individuals with markers of kidney disease or those with an eGFR of less than 60 ml per minute for 1.73 meters square on at least 2 occasions 90 days apart. So this has to be kept in mind that the markers of kidney damage includes albuminuria, hematuria, electrolyte abnormalities due to tubular disorders, various renal histological abnormalities, structural abnormalities detected by imaging, and a history of kidney transplant. So for the classification, you have to understand that CKD is classified based on the eGFR and the level of proteinuria, and this helps to risk stratify patients. So patients are classified as grade 1 to grade 5 based on the eGFR and A1 to A3 based on the albumin creatinine ratio. So, if we see that the classification is by grade 1 to grade 5 according to the eGFR. So we say grade 1 is eGFR if it's normal or high around 90 ml per minute. Grade 2 is a mild decrease, that is eGFR in the range of 60 to 89 ml per minute. Grade 3 is divided into grade 3A and grade 3B. Grade 3A is a mild to moderate decrease, that is around 45 to 59 ml per minute, while grade 3B is around moderate to severe decrease in the eGFR, that is 30 to 44 ml per minute. G4, grade 4 is a severe decrease in eGFR, that is around 15 to 29 ml per minute. And of course, grade 5 is kidney failure, that is eGFR less than 15 ml per minute. But we also have to keep in mind that kidney damage staging also includes the urine albumin by creatinine ratio. And that is basically the amount of albumin in the urine in milligrams to the amount of creatinine in the urine in grams. So we have this further classified into A1 and A2 and A3. A1 is mild to mild increase in albumin, which is around 30 milligrams, less than 30 milligrams per grams. E2 is moderate increase, which is around 30 to 300 milligrams per grams. And E3 is a severe increase that is more than 300 milligrams per grams. So let us take a patient who has come with, say, a eGFR of around 35 ml, so 35 ml per minute, so that fits into grade 3B. And if a patient has albumin by creatine ratio of, say, around 38 milligrams per grams, fits into grade 3B A2. So this is how we classify. Now, how does this classification help? Because if you see a diseased kidney, this is the blood, this is the glomerular filtration membrane, this is the urine. As the kidney gets damaged, there is a leakage of proteins into the urine. So this is what we are trying to prevent. CKD is increasingly recognized as a global health problem and a key determinant of poor health outcomes. The increased burden of chronic kidney disease in disadvantaged populations is both due to global factors as well as population-specific issues. I'm quoting a study from the Journal of Association of Physicians in India, in which they say that CKD affects 10 to 15% of the population worldwide. And according to 2013 Global Burden of Diseases, CKD attributed to around 9,56,200 deaths. And there has been a 134% increase from 1990. The prevalence increases with age, exceeds 20% in individuals more than 60 years and 35% in individuals aged more than 70 years. In India, prevalence of chronic kidney disease ranges from 6.3% to around 17.2%. Diabetes contributes to around 30% of CKD cases, and hypertension contributes to around 10% of CKD cases. So some data on the prevalence of chronic kidney disease in India, and we have various studies. We have the KIDS project, we have screening and early evaluation kidney disease in India, the SEEK India, cross-sectional studies, and overall CKD prevalence has been, say, around 17% in these various studies. So I have quote a study of the causes of CKD in India, and it shows current status of end-stage renal disease care in India and Pakistan. This is Chandigarh-based study in which it shows that we have, say, around 220,000 to 250,000 new patients every year, and around 50 to 60,000 patients on dialysis. Annually, there has been a 10 to 20% rise per year. The most common causes of CKD in India, diabetes and hypertension. So diabetic nephropathy contributed to around 31% of causes of end-stage renal disease. 16% was around undetermined. Chronic glomerulonephritis around 14%. Hypertension contributed to around 13%. Genetic causes like autosomal dominant polycystic kidney contributed around 2.5%. Obstructive uropathy around 3.5%. So the leading cause in India has to be diabetic nephropathy. So what are the possible mechanisms by which poverty in our part of Asia increases the burden of CKD? Of course, health behavior, lack of information on preventive behaviors, lack of knowledge on how to respond to an episode of illness, health beliefs and unhealthy behaviors. Of course, lack of access to healthcare, great distance from healthcare providers, and lack of out-of-pocket resources, as most of our people are paying out of their own monthly income. We have a lot of disparity in medical insurance. A lot of people don't have medical insurance. We have biological factors for the increase in CKD, like low birth weight, genetic predisposition, cumulative biological risk profiles, and of course, inadequate nutrition, and environmental factors like increased exposure to pollutants, increased exposure to communicable diseases, and very, very important, lack of clean water and sanitation in our part of this developing world. So younger people in India with CKD are more likely to develop end-stage renal disease before death. The younger they are, more likely that they will develop end-stage renal disease before death. So, as I told you, in the various stages of CKD, why they are important? Because stage 1, there is a mild to normal loss of kidney function. This often has no symptoms. The patient is asymptomatic. In stage 2, where there is mild to moderate loss of kidney function, the eGFR is say around 60 to 89 ml per minute. Here the patient may present with high blood pressure and some protein in the urine. Stage 3, again, which is divided into stage 3A and stage 3B, where there is a moderate to severe loss of kidney function, and which patient develops anemia and early bone disease, which we call chronic kidney disease, mineral bone disorder, CKD MBD. Stage 4, where the eGFR is around 15 to 29 ml per minute, where there's a severe loss of kidney function, and here the patient is symptomatic. Patient has fatigue, swelling, nausea, vomiting, and many more uremic symptoms. Stage 5, of course, when the eGFR is less than 15 ml, the patient goes into kidney failure and we start dialysis. So what exactly is the basis of my talk is, so can we prevent this progression of CKD or renal failure? So if we do not actively intervene and treat properly, the GFR rapidly declines and the patient goes into dialysis very fast, say within a period of 1 to 2 years. But if you catch them early, screen them, detect them early, and do all the preventive measures that I talk about, we can assume and help for a slow decline in GFR, and the patient has ultimately patient goes into CKD5, but we can give him more and more the number of years in which we can preserve his residual renal function. So routine testing for people who are at greatest risk, all diabetics, patients with hypertension, patients with a past history of acute kidney injury, cardiovascular disease, patients with structural renal tract disease, renal calculi or prostatic hypertrophy, and multisystemic diseases with potential kidney involvement like SLE, family history of an end-stage renal disease, hereditary kidney disease, and an opportunistic detection of hematuria. So these are the people whom you should keep on screening and trying to catch early. Frequency of eGFR testing in CKD, as I told you, grade 1, grade 2, grade 3 is divided into grade 3A and 3B, grade 4 and grade 5. And for grade 1, we recommend eGFR testing once in a year. Grade 2, and with the GFR is around 60 to 89 ml per minute, we say test every 6 months. Grade 3A and 3B, in which the eGFR is in the range of say around 30 to 59 ml, in which we say you test eGFR every 3 months. This is the group which you keep on testing and screening them every 3 months to prevent the decline in GFR. Of course, grade 4, in which the eGFR is 15 to 29 ml, in which you test every month. And of course, grade 5 patient is on dialysis. So what are the strategies that I'm going to talk about to delay the progression of chronic kidney disease? What I'm going to focus on: blood pressure control, intense glycemic control, prevention of metabolic acidosis, serum phosphorus control, of course, parathyroid hormone, vitamin D, hyperuricemia, and lipid lowering therapy. So we can have impact on the progression of chronic kidney disease. Intensive glycemic control lessens the progression from microalbuminuria, that is urine albumin by creatine ratio in the range of 30 to 300 milligrams per grams. Antihypertensive therapy with ACE inhibitors or angiotensin receptor blockers lessens proteinuria and the progression of CKD. Of course, dietary protein restriction, acidosis reduction, phosphorus control, and a BP blood pressure control below 130 by 80 is beneficial. So early treatment can make a difference. In this slide, if we are not treating at all, the time to go into ESRD is rapid. Of course, an early treatment, we can delay the progression of CKD and have more years. Chronic kidney disease and diabetes and cardiovascular disease. So there is a intersection in which CKD becomes a disease multiplier. So I put up the slide because we have to talk of this triad of diabetes mellitus, increased prevalence of diabetes in our population all over the world, giving rise to more diabetic nephropathy and chronic kidney disease, and all the complications of endothelial dysfunction and increased atherosclerosis, giving rise to more and more cardiovascular disease, morbidity, and mortality. So two simple tests will help identify chronic kidney disease in adults. One is eGFR, that is estimated glomerular filtration rate from serum creatinine using equations, and of course the urine albumin by creatinine ratio. Urine albumin to creatinine ratio on a spot urine sample. Nowadays, 24 hours urine collections for protein estimation are cumbersome and inaccurate and are not needed. You can just do a spot urine sample of a urine albumin to creatinine ratio. Diabetics should be tested once a year, and others at risk can be tested less frequently. I've already told you the frequency. So we have to remember that most of the chronic kidney disease patients may be asymptomatic and in early stages, but these are the warning signs to look out for in your clinic: hematuria, flank pain, edema of the legs, hypertension, signs of uremia like lethargy, fatigue, loss of appetite. If asymptomatic, patients may have elevated serum creatinine concentration, or look out for an abnormal urine analysis like the presence of casts in the urine, protein in the urine, anything abnormality in the urine, look out for CKD. Risk factors: age of more than 60 years, hypertension, diabetes, family history of CKD, frequent NSAID use, use of painkillers and over-the-counter medication for pain relief, and of course, race and ethnicity. So primary care providers are the first line of defense against CKD, and primary care professionals can play a significant role in early treatment, detection, and patient education. Therapeutic interventions for diabetic CKD are like those required for optimal diabetes care, like control of glucose, blood pressure, and lipids. A greater emphasis on detecting CKD and managing it prior to referral can improve patient outcomes. So chronic kidney disease is a part of primary care. We classify CKD by diagnosis: diabetic kidney disease, glomerular diseases, vascular diseases, tubular interstitial diseases, cystic diseases, and diseases in the transplant kidney like allograft nephropathy, drug toxicity, and recurrent diseases. With this, I come to CKD management, and after a brief review of chronic kidney disease, the stages of CKD, eGFR, and albumin creatinine ratio, we come to how do we prevent progression of CKD, in which I talk on. First, let's go to hypertension control to slow CKD progression. Control of blood pressure in CKD, how low do we go? So BP lowering is important therapeutic goal in patients with diabetic and non-diabetic CKD for slowing progression. In diabetic chronic kidney disease patients, BP target say around less than 130 by 80 millimeters of mercury, and in non-diabetic CKD without albuminuria can target around say 140 by 90 millimeters of mercury. This is a study by Fakka and Jafar in Nephrology Clinical Practice 2011. So what is the blood pressure control? What does the guidelines say? So let's go to how to treat hypertension and CKD. So initial therapy is a dual combination. We can use an ACE inhibitor or an ARB plus a calcium channel blocker, or you can use an ACE inhibitor or ARB with a diuretic or a loop diuretic. In step 2, BP is still not controlled. You can use a triple combination. You can use ACE inhibitor or ARB with a calcium channel blocker with a diuretic. And in step 3, the BP is still not controlled. You can use a triple combination plus spironolactone. That is, any case of resistant hypertension, you can add spironolactone 25 to 50 milligrams once a day, or any other diuretic. You can add an alpha blocker or beta blocker. You can consider beta blockers at any treatment step when there is a specific indication for the use. For example, a heart failure, angina, post-myocardial infarction, atrial fibrillation, or younger women with or planning pregnancy. So for patients with proteinuria, uh, ACE inhibitor or an ARB plus a diuretic, and for patients without proteinuria, ACE or an ARB is preferred. So let me talk of an important study. It's published in Annals of Internal Medicine 2005. It's basically effect of lower target BP on the progression of CKD. So this is a long time follow-up of the MDRD study, which is a randomized multi-center study in which we had around 840 participants, patients with predominantly non-diabetic kidney disease with a GFR of around 13 to 55 ml per minute. The antihypertensive treatment was randomized to low target blood pressure, that was a mean arterial pressure of less than 92, or a usual target blood pressure, mean arterial pressure of less than 107 millimeters of mercury. For follow-up, kidney failure, that is defined as initiation of dialysis or kidney transplantation, and the composite outcome of kidney failure or all-cause mortality. So what did this study show? That low target blood pressure was associated with reduced risk for kidney failure or composite outcome compared with usual target blood pressure throughout the extended follow-up period. In inhibition of the renin-angiotensin axis, in which ACE inhibitors and ARBs to slow the CKD progression. So we have a whole bunch of studies in which ACE and ARBs have been used to reduce renal events, and there is a meta-analysis of all these studies, like the RENAL study, the IDNT, HOPE study, in which baseline they have used ACE or ARBs like losartan, irbesartan, captopril, ramipril, and it has shown significant reduction in the composite events. So the lower blood pressure goal in diabetic patients, we have a randomized double-blind study, that is the RENAL study, in which we had around 513 participants, patients with type 2 diabetes and nephropathy. They were randomized, it was a double-blind study, into receiving losartan at 50 to 100 milligrams once daily with background antihypertensive therapy, or they were randomized to receive placebo with background antihypertensive therapy. And so what did they find? So this is a study which has been published in New England Journal of Medicine in 2001 by Brenner et al. And the treatment with losartan resulted in 16% reduction in risk of primary composite endpoint. Also, it showed that the risk of doubling of serum creatinine concentration was 25% lower in the losartan group than in the placebo group. Also, losartan reduces, the ARB losartan reduces the risk of end-stage renal disease by around 28%. So the risk of combined endpoint of end-stage renal disease or death was 20% lower in the losartan group than in the placebo group. And the treated systolic blood pressure values of more than 140 millimeters in those with nephropathy from type 2 diabetes significantly increases risk of nephropathy progression compared to those with values of less than 130 millimeters. So lower your systolic blood pressure, the lower the risk of CKD progression in diabetics. So there is a subgroup analysis of the advanced on trial, in which the advanced on trial, which shows that in patients at trial baseline with systolic blood pressures less than 140 millimeters, risk reduction in end-stage renal disease was greater than those with systolic blood pressure more than 140 millimeters of mercury. So now we come on to blood pressure reduction and the role of calcium channel blockers, ACE and ARBs versus calcium channel blockers in CKD. And calcium channel blockers are extremely popular in India, and they are widely used in chronic kidney disease. So I present a meta-analysis of effects of calcium channel blockers compared to ACE inhibitors and ARBs in patients with hypertension and CKD stage 3 and 4 and patients on dialysis. So methods, 21 randomized controlled trials, randomized 9,492 patients. It's a big study with hypertensive and CKD into CCBs and the two RAS blocker treatments. Results, no significant differences in blood pressure change, mortality, heart failure, stroke, or cerebrovascular events and renal outcomes between the two groups. Conclusions, calcium channel blockers also have similar effects on long-term blood pressure, mortality, heart failure, stroke, and cerebrovascular events, and renal function to RAS blockades in patients with stage CKD stage 3 to 5 and dialysis patients and hypertension. So results from the landmark All Heart and the INSIGHT study. So what is the INSIGHT study? It is intervention as a goal in hypertension treatment trial in which say around 6,300 patients, hypertensive patients, better outcome was seen, small was but significant in EGFR, and in the All Heart trial, that is the antihypertensive and lipid lowering treatment to prevent heart attack trial, the All Heart EGFR exhibited a significantly better preservation in the calcium channel blocker arm than compared with the diuretic and the ACE inhibitor group. So in hypertensive patients with or without chronic kidney disease, calcium channel blockers are also an excellent choice. Presence of microalbuminuria, use an ACE or an ARB and consider adding a calcium channel blocker. Absence of albuminuria and a preserved GFR, that is around 60 ml per minute, a calcium channel blocker can be a first step therapy. In the presence of diminished GFR without albuminuria, a calcium channel blocker can be used as first step therapy. However, a high percentage of patients will require combination therapy. So what are the goals of care in chronic kidney disease? So how do we slow decline the kidney function? Blood pressure control, that is albumin creatinine ratio less than 30 milligrams per grams. Try the BP control, keep the BP less than 140/90. If you have moderate proteinuria, that is albumin by creatinine ratio in the range of 30 to 300 milligrams per grams, try to keep the blood pressure less than 130/80 millimeters of mercury. And of course, if you have albumin creatinine ratio with severe proteinuria, more than 300 milligrams per grams, you have to keep the BP less than 130/80. Always remember, individualize your targets and agents according to the age, coexistent cardiovascular disease, and other comorbidities. Always see how you can individualize your treatment for your patients. There's no point in rapidly declining the blood pressure and the patient fainting and injuring himself of postural hypertension. So risk benefit should be carefully assessed in elderly and medically fragile. Always check labs after initiation of AS or ARB. If there is a less than 25% serum creatinine increase, continue and monitor. If the serum creatinine rise is more than 25%, stop the ACE inhibitors and evaluate for RAS or change the molecule. Continue until contraindication arises. There is absolute no EGFR cutoff. We have also better proteinuria suppression with a low sodium diet and diuretics. Avoid volume depletion in such patients. Always remember never to combine ACE inhibitors and ARBs. There are less risk of adverse events, impaired kidney function, and hyperkalemia. So after blood pressure control to progress for CKD progression slowing, we talk about intensive glycemic control and our target HbA1c in CKDs. So if we look at stage 1 with a normal or an increased EGFR more than 90 ml, keep the target EGFR less than 7%, target HbA1c, glycosylated hemoglobin less than 7%. If you have a mild decrease like stage 2 CKD, keep HbA1c around less than 7%. Remember, in kidney failure and when the eGFR is less than 15 or the patient is on dialysis, don't go for a strict HbA1c control. You can try to keep it more than 7. We don't want complications. So intensive glucose control for preventing ESRD. I present outcomes of advance on that is almost a follow-up of 8,495 patients for a median of 5.4 years. And this showed that intensive glucose control was associated with a long-term reduction in ESKD. This is the study which is presented by Wong et al. In Diabetes Care in 2016. We also have that intensive glucose control improves long-term renal outcomes. This is the follow-up of Veterans Affairs Diabetes Trial, VADT, for 15 years, and intensive glucose lowering reduced a composite renal outcome of development of persistent stage 3B CKD or severe albuminuria. So the goals of care in CKD and glucose control, target HbA1c around 7%, can be extended above 7% with comorbidities, or if the patient has a limited life expectancy or has high risk and is having repeated episodes of hypoglycemia. Risk of hypoglycemia increases as the kidney function becomes impaired. So declining kidney function may necessitate changes to diabetes medicines and renally cleared drugs. Modifications of other cardiovascular risk factors in CKD, of course, smoking cessation, exercise. Encourage all your patients to exercise at least 30 minutes, 5 days a week. Weight reduction to optimal targets. Lipid lowering therapy. So in adults, more than 50 years, statin when eGFR is more than 60 ml per minute. Statin or statin ezetimibe combination when eGFR is less than 60 ml per minute. In adults who are less than 50 years, statin if there is a history of known coronary artery disease, myocardial infarction, diabetes, or stroke. Aspirin is indicated for secondary but not primary prevention. So how do we detect and manage anemia, which is very commonly seen, anemia of CKD in our kidney patients? So in anemia, initiate iron therapy if the transferrin saturation is less than 30% and ferritin is less than 500 nanogram. We prefer IV iron for patients on dialysis and oral for non-dialysis CKD. Individualized erythropoiesis stimulating agents like ESA therapy. Start erythropoietin if hemoglobin is less than 10 grams and maintain hemoglobin less than 11.5 grams per deciliter, and always ensure adequate iron stores. Appropriate iron supplementation is needed for erythropoiesis stimulating agents to be more effective. Okay, so how do we manage bone complications, that is the CKD, MBD? It was earlier known as renal osteodystrophy, and now we call it CKD, mineral and bone disorder. Treat with D3 as indicated to achieve normal serum levels of vitamin D3. 2,000 units orally is cheaper and better absorbed than 50,000 units as a monthly dose. Limit phosphorus in diet with emphasis on decreasing packaged products. We may need phosphate binders, which I'll talk about in detail later on. Now we come to a very important topic, which is metabolic acidosis reduction. And it's very important to detect and manage metabolic acidosis. It usually occurs later in chronic kidney disease. Try to maintain serum bicarbonate levels more than 22 milliequivalents per liter. Correction of metabolic acidosis may slow CKD progression and improve patients' functional status. We have to understand that the normal pH is maintained around 7.4, and this is a very vital and tightly regulated physiological process. Kidneys eliminate around 50 to 100 milliequivalents of hydrogen ions. Kidneys also eliminate NH4 plus, and the lungs eliminate CO2. So emerging evidence shows that alkali therapy may preserve eGFR in patients with CKD who have normal serum total CO2 concentrations by mitigating adaptive kidney responses, that maintain normal TCO2 concentrations, but at the same time promote kidney damage. So this is a study which has been published in Kidney International in 2015, which shows that the risk of metabolic acidosis increases as the eGFR decreases to less than 40 ml per minute. The lower the eGFR, the net acid excretion decreases, which gives rise to metabolic acidosis. So there is a positive acid balance, and a TCO2 less than 22 milliequivalents is a surrogate assessment of bicarbonate and metabolic acidosis. So risk of metabolic acidosis in when the patient is having a reduced eGFR, hyperkalemia, reduced urinary acid excretion, smoking, anemia, and ACE inhibitor with an ARB use. So what is the mechanism of metabolic acidosis in CKD? So in CKD, we have acidemia, and this acidemia gives rise to RAS activation. RAS activation gives rise to interstitial fibrosis, and this interstitial fibrosis goes back and again increases the progression of CKD. Also, there is muscle catabolism releasing amino acids, which release ammonia. There's complement activation, which again gives rise to interstitial fibrosis. So basically, when do we initiate an alkali therapy? So always remember that you have to see that the TCO2, if it is less than 18, you can start sodium bicarbonate, 1300 milligram twice daily, that is say around 30 milliequivalents of bicarbonate per day. Or you can see if the TCO2, average TCO2 is in the range of 19 to 21 milliequivalents on 2 consecutive measurements. You can start sodium bicarbonate around 650 milligrams twice daily. So you titrate sodium bicarbonate to around 1900 milligrams twice daily and measure if the TCO2 is still less than 22, then you can titrate sodium bicarbonate right up to 1950 milligram thrice daily. So our target TCO2 should be more than 22 milliequivalents. So there are a lot of commonly prescribed agents, and in India we prescribe sodium bicarbonate tablets. We can also have sodium bicarbonate powder, and of course the various solutions we have given a detail of in this slide. And this has been published in American Journal of Kidney Diseases in 2019. It's a very recent publication. So why do we treat acidosis? And so there is a sweet spot that we have to keep the serum total CO2 levels, which is a surrogate marker of bicarbonate, in the range of say 24 to 26, because if it goes less than 22, we have an increased risk of chronic kidney disease progression. We have bone demineralization, skeletal muscle catabolism, and an increased risk of death. But if we increase it to more than 28, then we have an increased risk of heart failure, calcification, and again, it's not good for the body. So now we talk about phosphorus reduction, which also plays a very important role in your clinical outpatient practice. Remember, phosphorus is a very important mineral. It's important for cell structure and energy. It's mainly intracellular, around 70%. Bones have around 29%, and less than 1% of phosphorus circulates in the serum. The phosphorus is filtered freely in the glomerulus, and then it is absorbed in the proximal tubule under the effect of various hormones. If in chronic kidney disease, the kidneys fail to excrete the phosphorus, and they result in a positive phosphorus balance. CKD hyperphosphatemic phase, there's a new phosphorus reservoir, is the soft tissue organs, including the vasculature, and calcification, a hallmark feature of CKD. This is a very busy slide in which I want to talk about phosphorus and something very important, which is known as fibroblast growth factor 23, which is secreted by various osteocytes. And this binds basically to clotho, which is a transmembrane protein, and effectively helps in binding to the fibroblast growth factor receptors. So in CKD, when there is low calcitriol, low calcium, and high phosphorus, this gives rise to parathyroid hormone activation and secondary hypoparathyroidism. Accumulation appears to begin in CKD stage 3B of phosphorus. So the study published in Nephrology Dialysis Transplant in 2016. So what are the outcomes of hypophosphatemia? You have several negative outcomes. You have parathyroid hyperplasia, progression of CKD, increased peripheral arterial stiffness, endothelial dysfunction, vascular calcification, cardiovascular disease, infections, and decrease in the bone strength and bone mass with the increased rate of fragility and bone fractures. So how do we control phosphate? One is, of course, dietary phosphate restriction, administration of phosphate binders, effective control of hyperparathyroidism, and ensuring, of course, in CKD stage 5 and people who are on dialysis, ensuring adequacy of dialysis and the choice of dialysis regime best suitable for the patient. A grain-based diet has a lower phosphate to protein ratio and it's not absorbed by mammals. Moy et al. Presented in Nephrology Dialysis and Transplant in 2016 that 1 week of a vegetarian diet led to lower serum phosphorus and decreased the compensatory increase in the fibroblast growth factor 23. So foods may contain phosphate as a preservative. No guidelines currently in place to mention this. Dairy products and meat shown to be rich in phosphate and are easily absorbed. To try to avoid this in people with CKD, with high phosphorus. So we have various phosphate binders in the market, and we have various types of phosphate binders. Let's talk about aluminum. We have aluminum-based phosphate binders like aluminum hydroxide, which was used very rampantly earlier. We have calcium-containing phosphate binders like calcium carbonate, calcium acetate, very popularly used in India. We have calcium and magnesium containing phosphate binders like calcium acetate, magnesium carbonate. And of course, we have non-calcium containing phosphate binders like sevelamer hydrochloride, sevelamer carbonate, and lanthanum carbonate. We also have iron containing phosphate binders like sucroferric oxyhydroxide and ferric citrate. The phosphate binders are also mainstay of therapy to prevent rapid progression of CKD. Aluminum-based binders were quite effective, but rarely used in current clinical practice for long-term therapy due to the risk of aluminum toxicity. Calcium-containing phosphate binders, there is a widespread use, calcium carbonate or calcium acetate. There is an increasing concern of calcium loads, increasing vascular calcification concerns. Recently, calcium acetate with magnesium carbonate efficacy is almost similar to non-calcium binding agents. So what are the non-calcium binding agents? We have sevelamer hydrochloride or sevelamer carbonate advantage. There is a decreased rate of progression of vascular calcification as it is non-calcium based. Multiple studies have shown a survival benefit of patients treated with sevelamer. We have the Block et al. Study, the DCOR study. Lanthanum carbonate has similar advantages to sevelamer and the compliance is also higher. Iron-containing phosphate binders such as sucroferric oxyhydroxide and ferric citrate improves serum iron measures and decrease in IV iron and erythropoiesis stimulating agents used. Decreased fibroblast growth factor 23 cleavage. And, but there is a problem with all phosphate binders. There is a large pill burden. There is frequent dosing and the necessity to take at the time of ingestion of phosphate containing foods. Usually we try to tell them to take it as they consume immediately after lunch and dinner. So to detect and manage CKD complications of hyperkalemia, increased potassium plays a very important role, how to handle high potassium. So we reduce dietary potassium, we stop non-steroidal anti-inflammatory drugs, COX-2 inhibitors, potassium-sparing diuretics like aldactone. we stop or reduce beta blockers and ACE inhibitors and ARBs, and we avoid salt substitutes that contain potassium. It's very popular in India to use salt substitutes, and they may increase your potassium. So it has been well documented that a low protein diet also helps in delaying the progression of CKD, and a balanced approach to nutrition in CKD is with or without diabetes. So micro and macronutrient composition. So always try to remember to keep the total sodium less than 2,300 milligrams per day. That is around 1 teaspoon of salt is what is allowed in stage 1 to 4 of CKD. Keep the total fat around say 30%, and keep the saturated fat percentage of calories say around 10, less than 10% of the calories, cholesterol less than 200 milligrams per day, and the carbs should be forming around 50 to 60% of your calories. So in diabetes, in CKD stage 1, we go for 0.8 grams per day, grams per kilograms per day of protein. And when the patient is non-diabetic, we can, in stage 1 and 2, you can say keep around 1.4 grams per kilograms per day of protein. In CKD stage 3 to 4, when the patient is not diabetic, you can keep a protein intake in stage 3 and 4 of around 0.6 to 0.8 grams per kilograms per day, and keep the phosphorus say around 0.8 to 1 grams per day, and keep the potassium also low to around 2.4 grams per day. So we need to give a dietitian reference who can plan out the diet, thinking of the salt, protein, and potassium and phosphorus. So now we come to what exactly can primary care providers do, how do we prevent, and what is the role of the primary care provider. So we recognize and test early at-risk patients. We educate patients about chronic kidney disease and treatment. We manage the blood pressure and diabetes. We address other cardiovascular risk factors, monitor the eGFR and the albumin creatinine ratio. We should encourage our laboratories to report these tests, eGFR and the albumin creatinine ratio. Primary care providers can evaluate and manage anemia, malnutrition, mineral bone disorders, and other complications in at-risk patients. Can refer to a dietitian for nutritional guidance, consider patient safety issues in CKD, and the nephrologist and the primary care provider should co-manage and manage together a chronic kidney disease patient. Please refer the patient to nephrology when appropriate. So co-management, patient safety, and nephrology specialist referral. So I always believe that chronic kidney disease is a collaboration between the primary care provider, the internist, and the nephrologist. And we should provide pertinent clinical information to inform the consultant about the scheduled visit, timely referrals, and timely communication is what is needed to prevent CKD progression. Who should be involved in the patient safety approach to CKD? In stage 1, 2, and 3, primary care practitioner co-managing with a nephrologist in this stage, and timely referral, say when the eGFR is in the range of 15 to 30 ml, stage 4, of course, nephrology consultation, and when the patient goes into stage 5, start dialysis by the nephrologist. So what has been the impact of primary care CKD detection with a patient safety approach? So let's see a patient who has been not seen and who is not following up properly. Patient has been taken painkillers for gout relief. Patient has been given some contrast for coronary catheterization, has got treated with an aminoglycoside, has been on a diuretic while on an ACE inhibitor with hypotension and acute kidney injury. All these factors can give rise to rapid decline and a progression to ESRD. On the other hand, if the primary care provider and the nephrologist work together, we cut out the NSAIDs for over-the-counter medications. We give protection to prevent contrast nephropathy before a CT scan with a dye or before any coronary catheterization. We avoid nephrotoxic medications like herbal medicines and aminoglycosides. We avoid hypotension episodes. The patient baseline rate of renal function loss goes down and patient preserves the residual renal function. And so the improved diagnosis, it creates an opportunity for strategic preservation of kidney function. There are various CKD patient safety issues, that is medication errors by the patient, improper dosing, inadequate monitoring. Patient can have various electrolyte abnormalities like hyperkalemia, hypoglycemia, hypermagnesemia, hyperphosphatemia. Patient can have multi-drug resistant infections, and always keep in mind vessel preservation for dialysis access, that is for the creation of a arteriovenous fistula in the hand. Other patient safety issues like diagnostic tests, we have to keep in mind iodinated contrast media. Always remember that contrast media can give rise to acute kidney injury. Gadolinium-based contrast, that is, even gadolinium-based contrast media can give rise to nephrogenic systemic fibrosis, and various kinds of enemas which contain sodium phosphate bowel preparations can give rise to AKI and CKD. Of course, fluid management, prevent hypotension and cardiovascular failure exacerbation. Common medications, always keep in mind various common medications requiring dose reduction. Keep in mind allopurinol, gabapentin, which can give rise to increased drowsiness. Reglan has reduced the dose by 50% for an EGFR less than 40. Remember, metoclopramide can cause irreversible extrapyramidal reactions with chronic use. Narcotics, statins, digoxin. Keep in mind, digoxin in a CKD can give rise to severe hyperkalemia, methotrexate, various antifungals, aminoglycosides, and various other drugs. So the key points on medications in CKD: chronic kidney disease patients at increased risk for various drug-related adverse events. Several classes of drugs are renally eliminated. Consider kidney function and current EGFR, not just serum creatinine while prescribing medicines. You minimize the pill burden as much as possible. Remind chronic kidney disease patients to avoid over-the-counter or repeated use of painkillers. Do not go for ACE and ARB dual RAS blockade. Any medicines with greater than 30% renal clearance probably needs dose adjustment for CKD. Do not give bisphosphonates for an EGFR of less than 30 ml, and avoid gadolinium for an EGFR of less than 30. So what are the indications for referral to specialist kidney services for patients with CKD? So when do you refer? When does the primary care provider refer to a nephrologist? Any acute kidney injury or abrupt sustained fall in the GFR, glomerular filtration rate less than 30 ml per minute, that is GFR G4 to 5, persistent albuminuria, the albumin creatinine ratio more than 300 milligrams per grams, persistent, that is massive loss of protein in the urine, atypical progression of CKD, presence of urinary RBC casts or RBCs more than 20 per high power field, sustained and not readily explained, refractory hypertension, that is hypertension refractory to 4 or more antihypertensive agents, persistent abnormalities of serum potassium, cases of recurrent or extensive nephrolithiasis, and hereditary kidney disease. You should refer to a nephrologist. So there has been an observational study of early versus late referral in nephrology consultation. And so what did it show? That the overall mortality in early referral was around 11% compared to 23% in a late referral. 1 year mortality was around 13%, which was very high, around 29% in a late referral. There was an increased hospital length of stay. It was in an early referral, say around 13 days, and in a late referral, around 25 days in the hospital. And serum albumin at the time of renal replacement therapy was in an early referral around 3.6 grams per deciliter. Late referral, it was around 3.4. So it always shows that early referral is more beneficial to a CKD patient. So before I end my talk, we are facing a pandemic of COVID-19, and India is hit by COVID-19 in a bad way. So there is this pictorial slide which I wanted to put up, and it has been taken from Kidney International, in which kidney involvement is seen 15% of our patients show a creatinine rise, and around say 14 to 27% show raised BUN, blood urine nitrogen. 44 to 63% of patients, they show proteinuria. Say around 26% show hematuria. So acute kidney injury is an independent risk factor for mortality in COVID-19. So how does the COVID-19 affect the kidney? Because the COVID-19 binds to the ACE2 receptor, and this ACE2 receptor causes activation of the complement and podocytopathies. ACE2 is seen in very high amounts in the lungs as well as the kidney. In the kidneys, the ACE2 is seen in the proximal tubule and in podocytes. After binding, there is complement activation. There is the innate and the adaptive immunity pathway activation, giving rise to hypercoagulability and microangiopathies. Patient can also go into a cytokine storm in which there is an increase in interleukin 6. The COVID-19 can have direct cellular injury because it binds on the proximal tubules via the ACE and the DPP4. Studies have also shown that the virus has been isolated from urine and kidney tissues. So who are the people who are at increased COVID-19 susceptibility? Patients who have pre-existing CKD, newborns, pregnant ladies, elderly patients, and of course, in-center hemodialysis patients, because in-center hemodialysis increases risk of transmission in patients and staff. The impact of COVID-19 on CKD is not well known. So in management, we go for quarantine and supportive care. We give antivirals like remdesivir, favipiravir, CRRT, and in hemodialysis centers, how do we manage? We educate the hemodialysis team comprising of our technicians and our sisters. No group activities, personal protection kits to all our healthcare workers, and screening all the patients at the time when they enter into the dialysis unit, and of course, equipment cleaning with sodium hypochlorite. So in conclusion, this is a 2020 Kidney International article. Kidney involvement seems to be frequent in COVID-19 infection, and acute kidney injury is an independent predictor of mortality. Uremic patients are particularly vulnerable, and strict protocols in hemodialysis units are required. So as I end my talk, we go to the key points. And what we have learned is we have to keep diabetes and blood pressure controlled. If at risk, we perform screening tests. We reduce exposure to nephrotoxic drugs. We have the right nutrition. We exercise every day. And we know our family history. And take home points from my talk. Primary care providers play an important role in preventing rapid progression of chronic kidney disease. Please identify risk factors. Know your patient's GFR by using appropriate screening tools. Help your patient adjust their medications. Modify the patient's diet. Tell them to drink enough water. And partner and refer to specialists. Thank you. I have references which you can go through and how I made my talk. Dr. Mohit.
What an amazing presentation, so thorough. I think, that there was so much to learn from it. And as with any chronic disease condition, say hypertension, diabetes, similar to chronic kidney disease, I think the mainstay remains in the patient education. If they're aware of what to do, that leads to better outcomes in the long run. but I'm
Absolutely.
really impressed. So when you were talking, I made some notes and I have a few questions for you, if you don't mind me asking.
Okay. Yes.
So you mentioned about bicarbonate. If it is below 18, then it leads to mortality, it leads to increased mortality. Above 28, it leads to increased mortality. Is there a cutoff of bicarbonate where you start the oral bicarbonate supplements for the patients?
Yes. So as the slide we discussed that we try to keep the bicarbonate say around 22 to 26 milliequivalents. And in India, we have oral sodium bicarbonate tablets, which we start off because bicarbonate is very important in alkali therapy is very important in preserving residual renal function. So as the slide showed that, so there is a algorithm in which we can go back to. Can we do that, Dr. Mohit?
Uh, we can do that, or that will be
Yeah.
in your slides.
Okay.
I was just trying to see if there is any specific number, like is it 18 or 20 below which you start the oral bicarbonate?
Oh, usually, if it is around less than 20, we start off the sodium bicarbonate tablets.
Less than 20. All right, great. And you mentioned that it is stage 5, grade 5 renal chronic kidney disease patient you start the dialysis in. Are there in certain criteria in those patients, or is it every stage 5 patients where you start the dialysis?
I'm sorry, I did not get that.
So when do you start the dialysis in grade 5 kidney patients?
The initiation of dialysis. So, initiation of dialysis is, we have to understand that the dialysis is initiated when we see certain symptoms in the patient. Like we have a patient with the absolute indications are uncontrollable, very high potassium, and pericarditis. If the patient is going into cardiac tamponade or hemorrhage, we have fluid overload and pulmonary congestion, which is refractory to diuretics. And patient has uremic encephalopathy, that the patient is going into asterixis, patient is drowsy, patient has flaps, and we also have an absolute indication will be various bleeding diathesis, and then the patient is having uremic platelet dysfunction, intractable pruritus, and of course, even if the patient is asymptomatic, but the eGFR is less than 5 ml, if your patient is asymptomatic, go for dialysis. So, and of course, another point is refractory hypertension. You have patients who are CKD stage 5 with a low eGFR with more than 4 antihypertensive medications. There is a time to initiate dialysis.
Okay. And when do you perform the kidney biopsy?
Yeah. So one of the very important role of nephrologist is to decide when to perform a biopsy. And so we perform kidney biopsies when we have adult onset nephrotic syndrome, that is very high protein loss in the urine. We have patients with nephritic syndrome, that is proteinuria, blood pressure, or little RBCs in the urine. And when patient has an unexplained renal failure with normal size kidneys, we perform a renal biopsy. We also perform renal biopsies for various diseases with multisystemic involvement like SLE, amyloidosis. So these are the people in whom we perform kidney biopsies. Some of the contraindications are if the patient has very small and shrunken kidney, avoid biopsies because these are the people who tend to bleed and have massive hematomas post biopsy. We also avoid kidney biopsies if the patient has very high blood pressure, has a bleeding disorder, or we have a single kidney, because these single kidneys are dangerous to perform because it may, if God forbid, if there's a complication, it may give rise to nephrectomy. And we also avoid kidney biopsies for renal masses because if there's a vascular mass, there is a chance of causing more bleeding. So these are the patients in which we avoid a kidney biopsy.
All right. Now, that's very interesting. And there was one very interesting slide, the contributory factors apart from hypertension and diabetes. You mentioned NSAIDs. So apart from NSAIDs, can you put some light on, over-the-counter medications and chronic kidney disease progression?
Of course. Very nice question, Dr. Mohit. Over-the-counter medications is a very big problem in developing countries and all over the world, especially in India, when people go to the chemist and ask that I have joint pain, and the chemist or just over the counter takes NSAIDs like ibuprofen and diclofenac. This gives rise to kidney injury. Also, we have a lot of traditional herbal medicines in India and all over the world. In fact, there are a lot of studies that show that people all over the world use traditional Chinese herbal medicines for weight loss, for diabetes, for a feeling of well-being. One of the important ones was aristolochic acid, which gave rise to neuroepithelial tumors. Also, various Chinese herbal medicines have been shown which contain licorice for which promote for weight loss, and these people also develop renal failure. Traditional herbal medicines are all herbal medicines are not bad, but when these herbal medicines have complex active ingredients, these are the medicines that which are adulterated and which are not prepared in the proper dosage, which are not properly stored, and they can give rise to acute kidney injury, and patient may progress to chronic kidney disease.
Right.
So
So
try
this
to avoid
and yes, sorry.
medicines. Yes, Dr.
No, sorry, that NSAID problem you mentioned, that's very common. Even in US here, we see a lot of patients who keep taking NSAIDs, and no one is aware that NSAIDs can lead to high blood pressure. So they can damage the kidneys two-pronged by the high blood pressure and with the NSAID effect itself too. Yes, so
Very
right.
true. So one important point as you brought it up was that non-steroidal anti-inflammatory over-the-counter medicines, basically they inhibit the COX enzyme, the cyclooxygenase enzyme, and there is an inhibition of prostaglandin inhibition in the kidney, which is very important for the vasodilatation. So these people, they get kidney injury. Also, over-the-counter NSAIDs can give rise to acute tubular interstitial nephritis, and the patient may progress slowly into CKD. So this is one of the most common causes all over the world of kidney failure.
That is right. No, it's so important. And also with advances in cardiology, you mentioned about contrast, and also cardiology, radiology. We see so many radiology centers, and patients are getting more and more investigations in terms of contrast for the CAT scan and contrast for the cardiac catheterization. So how can that affect the kidneys, and how can we prevent the kidney damage with
Very
contrast?
true. As the diagnostic CT scans and cardiac catheterizations increase, uh, contrast media is one of the most important causes of contrast nephropathy, in which there is a rise in the serum creatinine of around, say, 0.5 milligrams per deciliter, or there is a more than 25% increase from the baseline, which happens within 48 hours. And the serum creatinine rises for around 5 to 7 days and then gradually comes down. So what they've seen is the contrast can be directly toxic to the renal epithelial cells because of the release of free oxygen radicals. Also, contrast decrease prostaglandins, which give rise to renal medullary hypoxia. The contrast medium, it also increases the vasoconstrictors like endothelin and adenosine. So this is the mechanism by which there is a renal injury, renal medullary hypoxia, giving rise to acute kidney injury. So you have to keep in mind that you have to always see the risk-benefit ratio of allowing your patients contrast media to be used. Always try to keep in mind that following cardiac catheterization, talk to the cardiologist to use minimal amount of dye. Try to use low osmolar or iso-osmolar contrast media rather than high osmolar contrast media. And always try to restrict repeat contrast media use immediately after the first exposure, because these are the factors in high-risk patients which give rise to contrast nephropathy. How do we prevent it? Hydration, hydration, and hydration. Always remember, post-contrast, for about 20 hours, there is a decrease in perfusion of the kidney. So the only thing that has really shown to prevent contrast nephropathy has always been hydration. There has been various studies say about use of sodium bicarbonate to prevent contrast nephropathy, and but uh, actually it is more that if we perfuse, we keep hydrating the patient depending on their cardiac status. We also see we don't allow concurrent hypotension to occur in the patient. We restrict and stop the use of nephrotoxic medications like aminoglycosides, painkillers, ACE inhibitors, and ARBs. So any patient who is, your patient is going in for a contrast exposure, try to cut out nephrotoxic medications, maintain optimal blood pressure, and hydrate your patients before contrast exposure.
Right. And you had a very good slide about COVID. You know, we are in the COVID era and it's on everyone's mind. All of us, you, I, everyone is affected by it. And uh, I'm pretty sure it is keeping you busy as well as a nephrologist.
Absolutely. We are
Right.
facing
So,
the COVID at home, and COVID has been a real scare to our health systems, and I'm sure you're facing it in America as well.
oh, absolutely. Out of track question. So during this COVID era, how has telemedicine help you keep your practice alive and help your patients?
Excellent question, Dr. Mohit. Uh, so telemedicine has been a real performer in these times because of first of all, we are trying to prevent our overwhelmed hospitals, and we are protecting our frontline healthcare workers. So you can screen the patients at home, and you can avoid everybody crowding in the emergency rooms and exposing our healthcare workers to more and more infection. Second has been that people with other chronic illnesses like cancer therapy, people undergoing palliative treatment, they need not keep on coming to the hospitals, and they can be screened and treated at home. The third thing is we can also, since we are doing a lot of telemedicine, it cuts down cost expenditure to the patient, and it is more economical to patients in far-flung areas in India. If they have access to Wi-Fi, they can access uh, good specialists in the cities. So these are the things which I think has been very important. That telemedicine has been playing a very important role in healthcare during COVID times. Of course, I would always like to bring in context the fact that traditional medicine with a good physical examination really helps because, but in COVID times, telemedicine has been a great help to us. My 2 points for a good telemedicine consultation for patients and for the doctor, it has been we have to keep in mind that we have to give very good Wi-Fi connection to the patients as well as in the hospital. There has to be very good acoustics for patient hearing. You can put soundboards and other things in the hospital. And of course, very good acoustics is very important part in telemedicine. And hardware, hospital needs to develop uh, the telemedicine department for uninterrupted Wi-Fi coverage, which is a problem in India.
No, that's very, very important. And I got similar feedback from my colleagues here. Let's say you're doing the first seeing the patient for the first time. Sometimes it's easy for that, or giving the opinion to your colleagues. Sometimes it makes it so much easier to do it on telemedicine, and also reaching the remote areas with the telemedicine. You mentioned in one of your slides, India is struggling with shortage of doctors, and the remote areas does not have a good physician availability. But I think that is one problem that can be solved with telemedicine as well, where you can reach from anywhere to anywhere.
Yeah, that's true. I completely agree.
Thank you so much for your time today. It was very enlightening, and we definitely learned so much about chronic kidney disease today. And Thank you again.
Thank you.